I think we've got a consensus here. And so perfect, gotcha. Wanted to make sure you had access to share your slides.
So let's see.
So everyone, if you don't know Dr. Doug Paauw, he is a professor of medicine, primarily at the UW, also director of medical student programs, and so is the master educator and is pinch hitting for us today on our academic half day. So we're really lucky to have him. So enjoy the talk.
Great. Well, I really appreciate being invited, and I appreciate all of you and the teaching you do for our medical students. I mean, when I talk to our medical students, I don't know what just happened. I think I kicked my computer. There we go. All the 90% of what our students learn or more are from you, and the enthusiasm, the care you give our students, your compassion, you're remembering what it was like to be a medical student, all of those things. I just can't thank you enough. So anything I can ever do to even do a minuscule amount of paying back how much I appreciate all of you, I want to do. So we'll talk about medical myths, and I'll start with just a little bit of kind of my theory on why these things occur, and I put them into different buckets, and you'll see in some of the ones we go through which buckets they kind of fall in. One of them is physiology that makes too much sense. We learned something in medical school that is physiology, and it goes, oh, I got it, I learned it, that makes sense. And we kind of think it's the only way something could happen in the body. And so we just close our minds to other possibilities. A really common one are case reports. Case reports, if you've ever read case reports, or if you've written case reports and gotten them published, they're kind of fun to write up because people don't hold you to the same standards to any other things you publish. It's basically, hey, I saw a cool thing, let me alert the world to it. Now, the problem with case reports is sometimes people can link a cool thing they see to a cause for it, and we usually haven't proven the cause. So case reports get out there, and then they become referenced and they become fact, and they don't get the same scrutiny as randomized controlled trials do and other things. Another thing is things used to be different, that in a different era, a different way things were done, they became established, and people didn't have evidence for them, but they became established. And sometimes we use different formulations of drugs and other things, so things may be different now than they were 50 years ago. And then the last one is just stubborn tradition. This has been going on since the beginning of time, and it's right, damn it, and don't cross me on this one. So these are kind of my theories on why these things occur. So let's just jump right in. And I'm going to give you cases for most of these. And if you want to pop into the chat what you think it is, and I want you to just answer not like what you think I am going to talk to you about, but what if somebody just asked you this, if there's a choice here that is what you sort of know or would do, put it in. 35-year-old woman with asthma presents for follow-up. It's October. You recommend she get the influenza vaccine. She tells you she can't take the influenza vaccine because she is allergic to eggs. What do you recommend? Give her the influenza vaccine, give her an oseltamivir prescription, have her take it if she gets symptoms, give her the nasal influenza vaccine, or give her a cell-based influenza vaccine. So those of you who are brave enough to answer, most people are popping in A, and I think I'd agree with that. And up until a year ago, my clinic had, oh great, we got the poll everywhere. Thank you, that's wonderful. I love poll everywhere. Perfect. So even my own clinic would ask everybody if they had an egg allergy, and I got angry with them because I said, why are you doing that when they say yes, we then might just ignore them? That pisses people off. So the right answer is A, just give her the influenza vaccine. And until a few years ago, we were doing all sorts of other things because we were worried about egg allergy. And what is the reason for that? And it's based on the fear that administering a vaccine that was grown in eggs and contained minute amounts of egg protein might cause anaphylaxis if the patient has IgE, antibodies against egg proteins. And it's not an unreasonable thought because, you know, I think you've all heard the case reports and things about people with peanut allergy, and, you know, they go in a room where somebody just ate peanuts, or they kiss somebody who just ate peanuts and then they anaphylax. So we know that there are people that have such high risk for anaphylaxis to any exposure. So this was always the thought. But then people started to say, let's look at people who got influenza vaccine who had egg allergy. One of the earlier studies was from over almost 25 years ago now, looking at kids, and it looked at kids with egg allergy confirmed with skin testing. They included 27 kids who anaphylaxed after eggs ingestion. So that's a group you wouldn't want to give it to. And all these kids who had gotten a flu vaccine, none of them got severe reactions. And the 4 mild were just tummy aches. They weren't anything that looked like a you know, IgE reaction. They were just, yeah, my tummy hurts for a couple of hours. So there was a lot of early information that said maybe this isn't as bad as it looks. So it took about, like, we'll see a lot of these myths. It sometimes takes 10, 15, 20 years before it makes mainstream. But back in 2014, this large study that looked at 28 studies, was really an analysis of all the studies that had collected individuals with egg allergy who had gotten influenza vaccine, and 4,315 patients, 656 had had anaphylaxis. None of them got a severe reaction when they got influenza vaccine. So this was pretty good data. Over 4,000 people who had happened to get it. Nobody died. Nobody got anaphylaxis. Nobody was really sick. And this drove the allergists to come out and say, you know what, this is not really an allergy that we have to worry about with influenza vaccine. We need to get everybody immunized with influenza. And so they came out with telling all patients with egg allergy of any severity should receive inactivated influenza vaccine annually using any age-approved brand. And initially, the first 2 years when they did this, they said they really should probably be an allergist's office because we think it's a good idea, but we got to be careful with this. And then they immediately backpedaled because they went, this is killing us. We got all these people who want to get the flu vaccine, taking appointments from people who really need it. And they saw very quickly all these patients did well. So they then said, you can pretty much do it. Now at this point, you can send them to Walmart, Rite Aid. You can do anything you want. You don't need to have them in a primary care office even to get this. So yes, give everybody the flu shot. Don't worry about egg allergy. Okay, let's stay on the vaccine world here. A 65-year-old woman presents for primary care. It's one of my patients. This history is her history. She is healthy with no active problems. Past medical history is significant for an episode of Guillain-Barré 7 years ago, from which she made a full recovery. She reports the Guillain-Barré syndrome occurred in the summer, and it took a full 18 months before she fully recovered. What do you recommend for immunization? So I'm seeing her for the first time, and she's really wide open. So pneumococcal vaccine, herpes zoster, COVID-19, and influenza vaccine, pneumococcal 13, pneumococcal 23, and herpes zoster, pneumococcal 13, pneumococcal 23 are no vaccines for her. So what do we do for her? So let's have how you all vote. Okay, let's see what you came up with. Okay, so most of you are just brave enough to just say immunize the heck out of her. And I think that's what I would do. And some of you were concerned enough, and nobody said no vaccines, but I think this is especially important in the COVID-19 era of getting these patients their COVID-19 vaccine. And many of them will say to you, my doc has not given me vaccines since my Guillain-Barré. I'm very hesitant to take a vaccine. So we're going to go through the data on this. And does anybody know where this all came from? Does anybody know where this teaching came from? Yeah, Mac, you give everybody ivermectin. I'm not surprised. So Lauren's saying polio vaccines. Yeah, so the 1976, you guys are all really young, so you weren't alive back in this era, but in 1976, there was a swine flu vaccine that came out very rapidly because They're very worried that it was going to be a pandemic. In 1968, there was a worldwide influenza pandemic that was pretty bad. It was nothing like the 1918, but everybody was still sort of on heightened alert, kind of like how we're all going to be forever because of COVID. And 1976, a very worrisome swine flu kind of popped up in sentinel areas. So they came out with a vaccine and got a widespread immunization on it. And there were more Guillain-Barré cases, and they were very real. I mean, it was a little blip, but it was a true blip. And so it got everybody terrorized about the influenza vaccine that caused Guillain-Barré syndrome. And from then on, everybody with Guillain-Barré was told, stay away from the influenza vaccine because it's a bad one for calling it Guillain-Barré. And that morphed into all vaccines. So that's kind of where this all came from. So the teaching was we just avoid it because it might increase the risk of Guillain-Barré. Now, the real issue is in this patient, they've already had Guillain-Barré, and is there any evidence that it increases the chance Guillain-Barré comes back? That's not a common event. Most people with Guillain-Barré, it's a bad thing. They don't keep getting Guillain-Barré. So that was never proven, but it was accepted as gospel. So what do? Let's look at people who had Guillain-Barré syndrome who actually get vaccinated. You know, not everybody's going to be happy with what their doc says on things. We know that there's going to be 10% of the population is going to disagree with everything. We're seeing that right now. So what happens to those people who say, damn it, give me a vaccine? So a total of 279 patients with previous Guillain-Barré received 989 vaccinations, including 405 trivalent influenza vaccine. No cases of Guillain-Barré syndrome occurred. Another study, 245 patients with Guillain-Barré responded to a survey of vaccination after Guillain-Barré diagnosis. 106 Guillain-Barré patients had received influenza vaccine with a total of 775 administrations. None of these patients with history of Guillain-Barré ever got recurrence of their Guillain-Barré syndrome. Now, what about COVID-19 and Guillain-Barré syndrome? That's a question all our patients ask us because they go, okay, I get that you have some data on influenza vaccine, but that COVID vaccine does a lot of bad stuff. And what I tell my patients is we're seeing a lot more Guillain-Barré after COVID than any issues with the vaccine. And COVID seems to be a virus that seems to trigger some Guillain-Barré syndrome. 73 reported cases of Guillain-Barré syndrome associated with COVID-19. Both symptomatic and asymptomatic COVID-19 are the triggers. 70% of these people ended up doing okay with Guillain-Barré. Obviously, this was published in April. This is data that was collected through December before the surge last year. So there are a lot more cases now than then. So how about in our actual mRNA trials? Were there any Guillain-Barré syndrome cases there? No, there weren't in any of the controlled studies for this. There was one case of Guillain-Barré 10 days after vaccination in the Johnson & Johnson trial, but there was also one case of Guillain-Barré syndrome in the placebo arm in the Johnson & Johnson trial. They've looked at in open reporting for vaccine side effects and been able to come up with a pretty good estimation of the risk of the Pfizer vaccine, 0.18 per 100,000 in the first 30 days after the first dose. But the community risk of Guillain-Barré is 1.1 per 100,000. So it doesn't appear to be higher than just your average risk of getting Guillain-Barré over any chunk of time. And there's been one case reported Guillain-Barré syndrome in a patient with previous Guillain-Barré who got a vaccine. So it seems to be safe. You know, again, this is a moving target, but I've been immunizing all my Guillain-Barré patients who with COVID vaccine, they've all taken it. I have no outliers on my Guillain-Barré patients, and they've all done well. So here's what the CDC and the Guillain-Barré Syndrome CAIP Foundation say, and I think this is very reasonable, sort of level-headed advice. If a patient had a history of Guillain-Barré syndrome within 6 weeks of receipt of the influenza vaccine, that should be a precaution. So we might be careful about giving the influenza vaccine again to somebody who had it right after an immunization before. I think that makes sense. And the GBS CDIP Foundation recommends avoiding immunizations that a GBS patient had received within 6 weeks of developing their initial symptoms. That makes sense to me. So that's kind of the CDC Foundation recommendation. So yes, we can immunize the vast majority of our GBS patients. A 59-year-old man is admitted with abdominal pain. He has a history of pancreatitis. A contrast CT scan is ordered. He reports a history of severe shellfish allergy when the radiology tech asks, and he is checked in for the procedure, you are paged regarding what to do. So that you're off doing your own things. You've already ordered this. You're ready to get the results, and they're saying, "Doc, what should we do? We're not comfortable just carrying through this order, giving this person their contrast because they have a shellfish allergy. So do we want to just say, go ahead and continue with the scan as ordered? I'm a doctor, listen to me. Switch to an MRI scan, switch to MRI with gadolinium, continue the CT with contrast, but give them some Solumedrol, continue the CT with contrast, give them IV diphenhydramine. So which of these would you do? Okay, so 52% said, I ordered it, go ahead and do it. That's what I would do. And then some of you said, well, how much trouble can you get into with a little Benadryl? That's kind of splitting the difference here. Just give them a little something because, they have a shellfish allergy. So why not give them some Benadryl? A few you want to give steroids and a few want to switch to an MRI. So I would just go ahead with the scan. Let's go through why. And I will tell you this person has a higher chance of having a reaction, but it has nothing to do with shellfish. And we'll go through why. So the myth came from fish and shellfish contain iodine, and allergic reactions to seafood are quite common, with prevalence ranging from anywhere from 2% to 6% of population. And so it's an iodinated contrast, so that might be where the problem comes from. So, one of the interesting things is this thing that has been known for quite some time. The people who give contrast still seem to believe it, or at least they did in 2008, long after we knew more about this. So a survey of radiologists and interventional cardiologists, 65 and 88.9%, asked about seafood or shellfish allergies prior to administering contrast. 35% of the radiologists and half of the cardiologists reported they would withhold contrast media or recommend pre-medication with steroids or antihistamines if the patient said they had a seafood or shellfish allergy. So the people who do it all day are worried about it. This is why we get calls about it. When the radiologist is worried, we automatically worry because this is their thing to do. When the interventional cardiologist gets worried about it and they're squirting contrast into people all day long and we aren't, then we worry about it. So why doesn't it make sense? Well, iodine is present in a lot of other things, and we don't tell people not to drink milk. We don't tell them not to eat bread. We don't tell them not to eat yogurt. We don't tell them to avoid all iodized salt. And then the allergy to shellfish is not due to iodine. It's due to paralbumin and tropomycin. So that's been shown. So the shellfish allergy is due to a couple of proteins. It's not due to anything that has to do with iodine, and that's an established fact. So it doesn't make a lot of sense that we kind of go, well, the ocean has a lot of iodine, so anything in the ocean could be the problem. That's kind of something that you might get from a naturopath or something. And I'm sorry if I've offended any naturopaths in the crowd. I don't mean to do that. I do have a lot of respect, but I don't have respect for the idea that natural things are inherently healthy, because tsunamis are natural, okay? And they can kill 300,000 people at a whack. So Mother Nature isn't necessarily kind. Mother Nature is like the rest of us, good days and bad days. So here's the deal. People who are allergic to things tend to be that group of people that we all know. The world's divided into no known drug allergies and long lists, right? And so they're in the long list group, so it makes sense they might be allergic to something else. So contrast reaction in 6 to 15% of people with seafood allergy, 14% of people with milk, egg, chocolate allergy, general allergies 13%, fruit allergies 13%, asthma 11%. So we don't ask these other things. It makes no sense we ask seafood if we're not going to ask about milk, eggs, chocolate, whether they have general allergies, and then try to figure out, does this group get Benadryl or something? We just are focused on seafood allergies, which seems to be really exclusive of all these others. So what are the current guidelines from the experts? The American Academy of Allergy, Asthma, and Immunology does not recommend low or isoosmolar contrast media or pre-treatment with corticosteroids and antihistamines for anybody with a seafood allergy who needs radio contrast. They say just go for it. The American College of Radiology recommends pre-treatment with steroids only for those who have had a previous moderate to severe reaction to IV contrast. So they're only going to give steroids to people who have shown that they have a contrast reaction before. So that's kind of when you get asked to give steroids to these folks, here's what their own academies are saying. Okay, let's talk just briefly about colonoscopy dogma, which is clear liquid diet for 1 to 2 days before colonoscopy, a gallon to go lightly, and be absolutely miserable. So this is part of why our patients, you know, when we appropriately say, hey, I'm ordering a colonoscopy, you need it, and they listen and they go, sure, doc, and then they don't get it. You know, we have as much as a 30 to 50% non-compliance rate, and it's not the colonoscopy. If any of you have ever had a colonoscopy, it's actually not a bad procedure. They give you some good stuff. You kind of go out, and then you wake up and you're like, okay, when are you going? We're done. And you're like, cool. That's not the problem. It's this crap, or this attempt to get you to crap. And I think the starving is really the worst part of it. You know, they put you on for these 2 days, you can't eat this, and then clear liquid diet. And the day before, when everything's running out of you, they give you liquids that you maybe not like, or the liquids you're allowed to drink. So that's an issue. And then I really believe 1 gallon of Go Lightly should never, ever be prescribed again. I mean, that is a terrible, awful thing to do. So let's go through the data on some of the newer colonoscopy information. So this is a study of low residual diet versus a clear liquid diet. 200 patients randomized to low residual diet versus clear liquid diet, preparing them for colonoscopy. The low residual diet allowed meat, eggs, dairy, bread, rice through the day before colonoscopy. I can live with that. I can figure something out I can eat in there that will make me not absolutely miserable. Patients in the low residual diet group had better bowel prep than those in the clear liquid diet group. 81% versus 52% were considered excellent bowel prep with a great p-value, less nausea, vomiting, headache, weakness, and hunger. Not surprising. So the people in low residual diet were actually doing okay, and the people in the clear liquid diet were pretty miserable. And looked like we actually did a little bit better with the low residual diet. Low residual diet and clear liquid diet compared with the meta-analysis in adequacy to bowel prep and detection of polyps, which is sort of the bottom line. Are we missing polyps because of this? Less nausea, vomiting, hunger, headache with low residual diet. Patients who took the low residual diet followed an increased willingness to repeat having a colonoscopy. That's probably good if these people make polyps, right? Compared to those who followed the clear liquid diet. So I really think this should be what we do. And a lot of our gastroenterologists are on board, but some of them have not gotten this. I don't know if they just want to abuse people, or maybe it's because it's so hard to get people in. They need to have a 50% non-compliant rate to have less than a 6-month wait time for a colonoscopy. But I'll tell you, you know, I have to get colonoscopies, and I do low residual diet, and I don't give a hoot what my gastroenterologist recommends. I'm looking at the data, and I've never had a failed one doing this. So now, how about the bowel preps? You know, there are some really new bowel preps that are very low volume bowel preps, so you don't have to drink the jug of Go Lightly. And if any of you have drunk a jug of Go Lightly, more power to you. The only bad bowel prep I ever had was the first one I had when I had a colonoscopy, and I got 80% through it, and I said, I'd rather die than finish this. So I said, I'm clear, I'm fine. And then I, you know, ended up having to repeat it because I wasn't, and you know, and Mac, I see you laughing. I know you're saying that's because Dr. Paauw's full of shit. So I see that, I know that, but that's okay. I'm told that by more than one person. Okay, so let's look at the different bowel preps. Lower volume bowel preps, Sue Prep is Movie Prep, Miralax are all superior to Go Lightly. Miralax Gatorade, which is just, you know, a lot of Miralax in a little bit of Gatorade. And so you don't have to drink volumes of it like in the Miralax in the Go Lightly prep. And patients taking the Sue Prep, Movie Prep, and the Miralax with Gatorade were all more likely to complete the prep than those taking Go Lightly. So I think that's why it turns out to be better, is that people can gag down 16 or 32 ounces, much more than a gallon of the stuff. So let them eat. Low residual diets are tolerable with less symptoms and work as well as clear liquid diets, and Go Lightly is a relic of the past. All it has going is low cost, and most of the insurance plans now are covering most of the low volume bowel preps as well. And the Miralax with Gatorade is pretty cheap too. Okay, a 30-year-old woman cuts her finger on a glass jar. She goes to the ED and needs to have sutures on the right ring finger. What would you recommend for anesthesia to prepare the patient for repair? Bupivacaine, lidocaine, 1% lidocaine with epinephrine, lidocaine 2%, or saline. So which of these are you gonna squirt in before you suture this person up? So what do you folks think? Okay, so yeah, most of us are doing 1% lidocaine. Some people bupivacaine, give them a little longer. A third of you are brave and are giving lidocaine with epinephrine, and 11% are giving xylocaine, and 4% are giving saline. So yeah, what I would do here is probably see lidocaine with epinephrine. And I was taught, I mean, this is another one where it was like, there was no question. It was like, you know, the first time I ever sutured anybody, they gave me the lecture about, okay, you use lidocaine, you use lidocaine and epinephrine, you know, these places, but don't ever do it in the fingers or toes. Don't do it in the genitalia. Don't do it on the ears because they're going to fall off. All that stuff's going to fall off, get gangrenous, and you're going to get sued. And so that was kind of what we were told. I think that's conventional wisdom. You never used anti-arterial field. Emergency, this is from a 2000 emergency medicine study guide. It's, you know, my guess is many of you have heard this before. So let's go through some data. And this, I love this study. You know, this is the one randomized controlled study I could find out there. It's a beautifully done study. It's small, 60 digital block procedures, 31 randomized to lidocaine with epi, 29 to lidocaine. Lidocaine with epi, 1 patient needed additional anesthesia. Lidocaine alone, 5 needed additional anesthesia. Digital tourniquet, though, was needed in 9 of 31 with the lidocaine with epi, but 20 of 29 with the lidocaine alone. So they needed to use a digital tourniquet to knock off blood flow because of so much bleeding if you didn't use the epi. 2 people had complications after lidocaine, none with lidocaine with epi, not statistically significant. But bottom line was it's every bit as okay, if not looking better for bleeding, to use lidocaine with epinephrine. 60 patients were still nervous. There is every ER doc in the world, is many of them are ready to testify against us if anything bad happens. So probably not enough data to change what we do. So why don't we ask the people who do this every day what they do? That is the hand surgeons. So this is a prospective, this is a study prospectively looking at the incidence of digital infarction and phentolamine rescue in a large series of patients who got epinephrine in their fingers and hands. From 2002 to 2004, 9 hand surgeons recorded each consecutive case of hand and finger epinephrine injection, which is their standard of care before they operate on the fingers. They inject them with anesthetic with epinephrine because it makes the bleeding less. 3,110 consecutive cases of elective injection of low-dose epinephrine in the hands and fingers. No cases of digital tissue loss. Phentolamine was never required to reverse vasoconstriction. So the hand surgeons do it. They don't have any trouble. That's enough for me. So I started talking about this years ago. And then I got a podiatrist in the crowd, and they go, you know, we've been doing that forever. You know how much mess it is when toes bleed. We always inject them with epinephrine. So I looked in the podiatry literature, 18,000 patients records over 14 years reviewed, plus an additional 5,000 records from the author's practice spanning 27 years reviewed for foot surgery patients, all deemed healthy, 65,000 digital surgical procedures reviewed that used lidocaine with epi, no complications. Look when this was published, 1971. Remember that textbook thing was 2000. So this is, the podiatrists have known about this long before we have, and they're like, yeah, we use this all the time. Literature review, 39 studies of epinephrine digital blocks in fingers and toes, no digital necrosis or gangrene in any patients. And I looked and found like some really wild things, like one where a person was freaking out because they had a bee sting and they had bee sting allergy, and in all the excitement to give themselves their EpiPen, they embedded it deep into the middle of their hand and they squirted their EpiPen into their hand. I don't recommend squirting an EpiPen into your hand because the amount of epinephrine is dramatically higher than in lidocaine with epi, but that person did not lose any fingers or anything. And then just talking about, you know, as I say, the fear is that you'll get sued and all that stuff. I was approached by a lawyer group, because to defend a doctor who, a woman had lost a couple of toes. And it was a bizarre case because this woman had warts on her foot, and this doc had injected her with Candidal, which is something that the dermatologists do for this. And this was a family med doc, and he had not given her lidocaine with epi, but when the toes fell off, the prosecution said he must have mistakenly given her lidocaine with epinephrine and just recorded it as this. And so I was thrilled. I was like, prosecution, you're going down here, you know. Now, the reason she lost her toes is I think they got an immunologic reaction. She had a really remarkable vasculitis, probably from the Candidal, which is not a common thing, but you know, they were going to sue on bogus stuff, so that they went down. So that was good. Okay, a 46-year-old man lives in Tacoma, Washington, is seen for fatigue. He has no significant past medical history. He is not taking any medications. Hemoglobin 12, hematocrit 37, MCV 103, TSH 1.2. So this guy from Tacoma got a crit of 37, MCV of 103, TSH of 1.2. What workup do you recommend for him? B12 folate testing, alcohol history, B12 folate testing, alcohol history, B12 testing. So what are you going to do for this guy? Okay, let's see what you got. Okay, so it looks like a bunch of you, 33% wanted to get B12 folate and alcohol history, very, very good. Or that was alcohol history, B12 and folate testing. And then a lot of you want to do alcohol history and B12 testing, absolutely correct. So what I wanted to talk about here was, in medical school, I was just hammered home. Anytime anybody's high MCV, you get B12 and folate. And really, we've moved away from doing folate testing almost ever. I mean, there are a few indications for folate testing, but it's not just the elevated MCV, which is what I was taught, and that is still very, very prevalent. So let's go through the data. And we were taught this because before routine fortification of grain products with folate, anemia due to folate deficiency was sometimes seen. I saw patients with folate deficiency when I was a resident, especially patients who had alcoholism. I would see an occasional folate deficiency anemia, and we'd work it up and we'd treat them and we'd give them folate, and we made sure they took folate every day. But once we started to fortify to try to prevent neural tube defects, folate is everywhere. So it really has changed how common we find a positive folate test. This is in Canada, 11 of 2,154 serum folate levels were low, and 4 out of 556 RBC folates were low, but nobody with low folate was at the reason for their anemia. So they found other causes that actually corrected when they fixed them. So their point here was, it really doesn't seem well to test. In the United States, this is a study that looked at 10 years of folate testing. Almost 85,000 serum folate levels were measured, 77,000 individuals, 47 were deficient, 0.056%, so well under 1%, 166 low normal, and almost all were in the normal range. So again, we almost never see this. So if you have somebody who has a real bowel absorption problem that's severe, or somebody who's had their gut removed and isn't getting replaced, doesn't find a way to get the folate, that's a totally different thing about testing, but it really shouldn't be part of our MCV workup. The Choosing Wisely campaign, the American Society for Clinical Pathology, who makes all the money off all these, have said, do not order red blood cell folate levels at all. So they are not hemming and hawing here. Now, when we see macrocytosis in our own clinics, most of it is going to be alcohol, and I think all of you know that and have seen that. When you look at people who just have a little blip, like a little over 100, this study of 300 consecutive primary care patients, MCV over 100, 4.7% were anemic. In 80% of the men and 35% of the women, the cause was alcohol. No cause was found in 6.8% of the men, 35% of the women. And so when you see an MCV over 100 without an anemia, it strongly shouts alcohol. Okay, that really shouts alcohol. Anemia with an MCV over 100, sort of a mild anemia. Yes, it's probably still alcohol statistically, but then it could be B12. It could be myelodysplasia early. There are other things in our differential. Okay, 32-year-old man is diagnosed with GRD and prescribed metronidazole. He has no other medical problems. He will be the best man at his brother's wedding tomorrow. What advice should you give him about alcohol use at the reception? Do not take metronidazole the day of the wedding if you will be drinking alcohol. Take metronidazole, but don't drink alcohol. It's okay to drink alcohol. So which of these do you want to, which of these are you going to do? And I'll tell you this, you know, if you order metronidazole on any of your patients, the prescription bottle will have a martini glass with a big X through it. That's on the prescription bottle. So what do you recommend here? Yeah, I think the right answer is C, and that's as best I can do by looking at data. Now remember, a couple of caveats here. This is a 32-year-old guy who has no medical problems, okay? So this is not my 90-year-old man who has ejection fraction of 11% and has cirrhosis. You know, it's not that guy. It's not like most of the people we take care of, but this comes up all the time, and the guy's going to a wedding, and are you going to tell him to not drink any alcohol at the wedding? You know, he's the best man. He's going to be doing a toast. Or are you going to say, don't take the metronidazole on the day? It's like, no, the answer is neither of these. It's okay to drink alcohol. Now, I will tell him that, you know, if you drink 9 to 10 drinks, you may throw up, you may flush, you may feel awful. And somebody may tell you that it's metronidazole, but you just got really drunk and you had a bad reaction to the alcohol. So let's go through some of the data, and we'll go through a little bit of what we have there. And this is because the pharmacy still put that warning on there. That's why Mac got yelled at, because, you know, it's like, well, if the pharmacist won't even back me up on this. So let's go through. And here's where the dogma is. The dogma, and you all know this, we've advised patients don't take alcohol if they're taking metronidazole, because they may get a disulfiram-like reaction between alcohol and metronidazole. This is the standard wording given by physicians, appears as contraindication. The prescribing information is well accepted, and it's accepted as proven reaction. And my argument is it's not a proven reaction, and we'll give you the one controlled study out there. So if you look at where this came from, if you look at reports of published literature between 1969 and 1982, there was no convincing evidence this reaction really exists. 6 of the case reports involved 8 patients who were evaluated. So there were a few case reports. This is one of those ones from the big bad old case report deal. So these said that, you know, people had a metronidazole prescription, they drank alcohol, and we've been looking for this, and look, here it was. One patient died. The patient who died did not have a metronidazole prescription in hand. They'd never been prescribed metronidazole, but they were convinced that what they saw was a antabuse-like reaction. Now, the death probably occurred because their head had been bashed in and they had massive bleeding in their brain, but that was discounted in the case report. So it's not proven, and they didn't show in any of these case reports data to show that there was evidence of increased acid aldehyde levels in the blood, or anything that maybe you might think about physiologically that had been purported before. They didn't have proof of any of those things. So does metronidazole increase blood acid aldehyde levels? So we have a rat model. The rats are pretty easy to study because the rats don't really need informed consent, and we haven't really met any rats yet who have argued about getting the alcohol. So they're pretty easy to study. What is found in the rat model is metronidazole can increase intracolonic, but not blood acid aldehyde levels if they get alcohol metronidazole. And the reason for that is that metronidazole changes your bowel flora. I think all of you are aware of that, and it doesn't surprise you that metronidazole has anaerobic activity, that it may affect and let aerobic gram-negative rods grow much better if you knock out anaerobic flora. And that happens in rats. Rats treated with metronidazole had increased growth of Enterobacteriaceae, an alcohol dehydrogenase containing aerobe, which could be the cause for the higher intercolonic acid aldehyde levels. But what they found was, as they tested the blood of these rats, none of them had higher blood acid aldehyde levels. And most importantly, they didn't find any evidence of an inhibitory effect on hepatic or colonic alcohol dehydrogenase or aldehyde dehydrogenase effect. And that's always been the purported mechanism. So let's get to a randomized controlled study. Small placebo-controlled randomized trial, 12 healthy participants. Where do you think you would find 12 healthy participants who would like money and alcohol? College, yeah, medical school is the correct answer, James. That's right. College, I always say it's WSU, just to say it because we're all Huskies here, and that's kind of well known for WSU. But these are medical students, yes. So half of the study participants received metronidazole 3 times a day for 5 days. The other half got placebo. So it was well done, and I like that they gave it for 5 days. So if there was an effect on bowel flora, we get it. If they just gave it at the time of the alcohol, then we wouldn't be able to go back and say bowel flora changed. All participants then got alcohol, the promised alcohol, 0.4 grams per kilogram, with blood testing being done every 20 minutes for the next 4 hours. Blood was tested for alcohol concentrations, acetaldehyde levels. The study participants also had blood pressure, pulse, skin temperature, and symptoms monitored during the study. There was no difference in blood acetaldehyde levels, vital signs, or symptoms. So they all felt pretty much the same. This is the data I look at for the advice I gave that 32-year-old healthy person. I figure that's kind of like that's a good average medical student, maybe a little older than our average medical student, but fits into this study, and it was safely done and monitored. Okay, 55-year-old patient of yours requests a new prescription from you at a routine appointment. She will be traveling internationally next month and wants to replace her emergency medication kit. As the medications in it from like 5 years ago, ciprofloxacin, loperamide, and oxycodone, have all expired. What do you do? Do you replace? What do you do for this person? Do you replace the prescription for Cipro? Do you replace all 3 medications? Do you tell the patient that all the medications should still be fine? So this happens all the time. We got patients that want to have their emergency medication kits. They're like, I'm traveling to the, areas where there isn't a doctor for 5,000 miles. I want all these different medicines. What if I get diarrhea? What if I hurt myself really bad? What if I get traveler's diarrhea? What if they want a little bit of everything. I'm sure you've all met this person. Okay, so 23% wanted to say we'll replace the Cipro. Maybe and that might be a good answer, because we may not want them to use the Cipro for traveler's diarrhea because of some of the warnings on fluoroquinolones. Maybe you thought the Cipro would expire and it was bad. And then 77% just tell the patient all the meds should still be fine. That's always been what I've said long before I had any data, because I don't want to deal with this. It's like the end of the visit, and they're like, oh, by the way, I'm running 10 minutes late because I covered an extra 2 problems. It's like, oh, by the way, refill all these bogus meds that I just want to carry around with me. So I always just said, oh yeah, they should still be fine. And now I actually have some data that back me up. So yeah, tell them it should be fine. So the expiration date on medications is not the date that they go bad. It's not the date that they turn them into a hairy ogre if they take them. It is just a date that is required by the FDA, that the manufacturer promises that they have tested that they have 90% potency. So they pick a date, maybe it's 18 months, maybe it's 2 years in the future. They study their lots at that point. If they're 90% potency, they can say that's our expiration date, and then they can mark every lot to have a 2-year or an 18-month expiration date. The question was, what happens a year after that, or 4 years after that, or any time after that? Can these meds still work? And the group of people who cared about that, who actually ran this study, was the US military, because the US military has to have a huge stockpile of medications for not only the troops, but for all of us. So the US military handles stockpiling all of the fluoroquinolones for the next anthrax outbreak. And if we need to give 30 million Americans fluoroquinolones, they got to have enough around. So the idea that they could potentially extend the shelf life instead of tossing this stuff every 18 to 24 months is very appealing from a cost standpoint. So they studied this. They looked at 122 drugs representing 3,005 lots. 88% had over 90% potency a year past expiration, with the average extension And remember, the extension was, when does it fall below 90% potency, was 5 years. 80% potency probably still works for most drugs. Cipro, the average time was 55 months, doxycycline, the average time 50 months. So we were out about very close to 5 years for both of the antibiotics. Now, this is more interesting to me. How about if you forget about drugs for 40 years and study them? Okay, this is a pharmacy, an old family-owned pharmacy that had a back room that they put some compounds that they didn't use much anymore, and they tended to be things like Fiorinol, Fioricet, some of these popular pain reliever compounds from the 70s, and then they just stopped using them there, and they just stuck them in a back room because you never know, and then they forgot about the back room. And this was no special treatment was given to these. They were just kind of in a back old room. And then they dug them out, and they looked at them up to 40 years afterwards. 12 of the 14 compounds tested were at concentrations at least 90% of the labeled amount 40 years later. Codeine, hydrocodone, acetaminophen were among the medications studied that were pain potency. The only thing that really caused a big breakdown was aspirin. Aspirin did break down. So I tell my patients, if aspirin's important to you for whatever reason, and certainly if it's for you have unstable coronary disease, you better not be cheap and keep your aspirin fresh because it can break down. But all the others, probably if you're using them here or there, I'm not giving you more oxycodone. You better keep that stuff for 40 years. If you really think you need to keep it for that one day, you're going to be hurt. And I'm not giving you more just in case. Now, here are the other questions I've gotten when I've lectured before. What about epinephrine? Epinephrine's a liquid. We're talking about pills. So some really interesting epinephrine data. Original parenteral epinephrine remains sterile and detectively pure for more than 2.5 years after expiration. Epi Pens less than 25 months past expiration contained at least 90% of the labeled amount. And this last one, they talked to nurses and doctors who had expired EpiPens and said, just give them to us. 1 to 50 months past expiration, all had over 80% of label concentrations. And these were things that were in glove compartments. They were getting up to 100 degrees down to minus 10 degrees. These were things that were in cabins where they just left an EpiPen in their cabin just in case. So these were not climate controlled EpiPens. So it appears that epinephrine stays very, very solid. Now, do I feel strong enough without a strong statement from a allergist that we can use expired EpiPens? No, I don't. But I tell my patients, don't throw them away. I said, the more EpiPens you have around, the better. If you can't find that brand new one, I'd rather have you have one in every room in the house so you jam something into you. So I tell my patients, don't just throw them away. You can keep them for your backup, hide them in the places, just have them all over the place. Hopefully your kids don't pick them up and start injecting themselves. I don't tell people lock up EpiPens like, they better be locking up firearms if God forbid they have them. But, I do like EpiPens around, and that's my advice. There's no guidelines on what to do with expired EpiPens, but a lot of people have questions because I have patients who can't afford their next EpiPen. I'd rather have them use an expired one than nothing. What about eye drops? That's the other one. Eye drops are more valuable than Bitcoin. Okay. I mean, eye drops, you know what a gallon of an eye drop is? It's something like $35,000 something for a gallon of eye drop or something. So our patients don't want to throw them away. And the only study I could ever find was this one where looked at travoprost 6 to 12 weeks after its expiration date. And they compared the efficacy of people breaking open a new bottle versus the 6 to 12 weeks after expiration date, and there was no difference. Now, I don't know beyond that. That's all I can tell my patients about eye drops is, maybe up to a few months after it, if you want to squeeze out the last drops out of that bottle, you probably are fine doing it. Now, the other thing that comes up is, can you die from an expired med? And the answer is, at least from pill form, no. The only thing that ever has anything bad that's ever happened is tetracycline, and it caused Fanconi's syndrome, but that was an old formulation that was removed from the market in the early 1980s. So there is no current drug that can kill you when it expires. It may not work and you may die if it's, if you're banking on penicillin from the 1930s that you found in your great-grandfather's closet somewhere and you have pneumococcal pneumonia. I guess if it was totally destroyed, it might be a problem, but it won't kill you in and of itself. I'm going to finish with a couple of my all-time favorite myths. 82-year-old woman is evaluated for fatigue. Lab eval reveals a hemoglobin of 8 with an MCV of 114. B12 level is 90, which is very low. Folate level was obtained because that's what people do, and it was normal. Urine methylmalonic acid level was high. What do you recommend for this patient? Getting a Schilling's test, oral B12, a blood transfusion, then IM B12 monthly, or an IM B12 load first, then monthly B12 injections. For this little old lady with a hemoglobin of 8, what do we do? Schilling's test, oral B12 daily, blood transfusion, then IM B12 load, then monthly IM B12. Okay, so it's hard. I can't even find a way to get a Schilling's test these days. I'm not sure. What I think people do, sort of, what people will do now is do antibody testing instead of that. But if we want to test, generally we just figure out they have pernicious anemia and treat them. So 40% of you gave oral B12. That's what I do. I've been doing that since the mid 90s and have not had a problem treating any of my patients with pernicious anemia. And then some people giving blood transfusions, some people giving the load. So the point here is oral B12 works very well. And we've had data dating back to the 60s on this one, and it still hasn't taken hold. So the reason that the early studies from the 40s and early 50s didn't work is they used tiny doses of B12. They were really focused on animal intrinsic factor, which didn't work. And they often got antibodies to the animal intrinsic factor. None of this made sense. They just did it and they said, this failed, so we got to inject everybody. But back in 1968, there was this well-done study from Sweden, and a lot more pernicious anemia in Scandinavians. 64 patients with established B12 deficiency from 3 Swedish medical centers all got 500 to 1,000 a day of B12. All 64 normalized their serum B12 levels, all normalized hemoglobin hematocrit. They followed them for 6 years. Nobody got neurologic abnormalities. Nobody had a return of their anemia, and all kept normal B12 levels for the 6 years they followed them. So they came out with 100% success in people with true pernicious anemia. Sound the horns, we got a new day is dawning. Well, no, it didn't dawn. And the reason is this was not published in New England Journal of Medicine. It was published in Acta Medica Scandinavia. And I know that everybody goes there first for their medical information. So this did not make mainstream. This was before the internet. I think now this type of thing might get buzz out there and might get tweeted, and pretty soon people will be doing it, but not in 1968. So by 1998, the study was repeated, and this was published in Blood. That's read a little bit more. 38 newly diagnosed B12 deficient patients randomly to get IM B12 or 2,000 micrograms. It's the 90s, bigger and better. B12's levels, methylmalonic acid levels measured. The IM B12 group, it went up to 325. Methylmalonic acid level dropped, so that's good. But the oral B12 level went up even higher than the IM. Went up to 1,000 picograms per milliliter, and the methylmalonic acid level went down even more. So this seemed to work better than giving IM B12, and it's cheaper and it's easier. Now, some of you are going to ask, what if I have a gastrectomy patient? What if I have a gastrectomy? They don't make intrinsic factor because they don't have a stomach anymore. This is a study of 26 patients followed after total gastrectomy, all got only oral B12, 1,000 micrograms, being followed up 20 months, all had normal vitamin B12 levels. As you all remember, you get B12 absorption in the small intestine. And the bottom line is, if you give enough B12, there is mass action, so you can overcome the fact you don't have intrinsic factor. That's why we can use it in pernicious anemia. So oral B12 supplements effective and safe in patients who underwent total gastrectomy. So what does Cochrane Review say? Well, they say low quality evidence shows oral and IM B12s having similar effects in terms of normalizing serum vitamin B12 levels, but oral treatment is much cheaper. They call it low quality evidence because there aren't that many studies. I showed you the 2 biggest studies. It's being done in Scandinavia since the 60s. It works. I have not given a B12 injection to a person with pernicious anemia since the 90s. Again, it works. So I think this should be the standard of care. It's easy and cheap. So the reason is because we get independent intrinsic factor absorption. and 1.2 to 1.5% of the dose is absorbed in patients with pernicious anemia, independent of intrinsic factor. If you give 1,000 a day, you're giving a ton. Okay, my last one here, and then we'll let you go. A 29-year-old woman presents her evaluation. She reports that she has been having frequent headaches over the last 12 months that include pressure pain over her forehead, under her eyes, and over her cheeks. She usually has nasal congestion as well. She has not had any fevers or purulent nasal discharge. What is the most likely problem? So she says that she has pressure pain on her forehead, under her eyes, and over her cheeks. No, she usually has nasal congestion as well. No fevers or purulent discharge. Does she have cluster headaches, migraine headaches, sinus headache, or tension headaches? Okay, so we got 9% said migraine headaches, 59% sinus headaches, and a few people, or actually it looks like 27% sinus headaches. If I get this right, 27% tension headaches, 59% sinus headaches, and 9% migraines. So those of you who chose migraine, absolutely correct. This is one of the more common forms of migraine, and I promise you it's almost never correctly diagnosed outside of headache clinics. And this is one of those things that just hasn't gotten out there, even though there have been a number of studies, and this comes up very, very frequently. And let's go through some of the data here. So this is a study from 2004, almost 3,000 patients who reported 6 headaches during the previous 6 months, self-diagnosed or physician diagnosed as sinus headaches. 88% of these patients met International Headache Study criteria for migraine headache or migrainous criteria. Most had sinus pressure, sinus pain, and nasal congestion. What moves us away from thinking a sinus headache is these people tell us both of their maxillary sinuses hurt. Their frontal sinuses hurt. They don't say, I only hurt here. Sometimes they do, but you can get both. And this study showed that. 100 recruited who believed they had sinus headaches all got detailed history and physical exam and given a sinus, and they were all given a final diagnosis based on International Headache Society criteria. They were the same: migraine with or without aura, 52%, probable migraine, 23%, chronic migraine with medication overuse, 11%. So almost 80+% had migraine headache or one of its variants. Very important, 76% of migraine patients reported pain in the distribution of the second division of the trigeminal nerve, and 62% had bilateral forehead or maxillary pain. This is a study that just shows that these patients can be misdiagnosed for a long time. The study included migraine patients with past history of sinusitis, 130 patients recruited. Of these patients, 81.5% were misdiagnosed as sinusitis. The mean time delay of migraine diagnosis was 7.75 years, range 1 to 38 years. And then this is a treatment study where they got 54 patients who had a history of sinus headache, and all of these people got sinus endoscopy and CT scans of their sinuses, and they had to be negative to be qualified for the study. They had a pretty big dropout rate. Only 38 completed, and the ones that dropped out all dropped out because they felt that these people were quacks because they told them they didn't have sinus headaches. After the normal endoscopy and normal CT, they said, "You don't understand me. I have sinus problems." I don't know if any of you have met any of these patients. They're out there, they go, "You're a dumbass, I'm out of here." This is a controlled study, and they told them what they were doing. And once they said, "We're not going to treat you with antibiotics for sinus headaches, we're going to do something else," they ran. That's pretty amazing. Anyway, 38 people were brave. They completed follow-up. 82% had significant reduction in headache with triptan use. 92% had migraine-directed therapy success. So it shows if you get these patients and you treat them for migraine, you're going to be quite successful. I'm sure you all have somebody like this in your panel. Some of you might be this person. These things happen. So just remember this. Hopefully this is something new you learned today that can be helpful. Let me go back through the chat and see if there are questions we didn't answer.
Yeah, there was one earlier on, Dr. Paauw, from Jordan Herman regarding kind of this conventional wisdom and going against it. Wondering if malpractice suits are more common when you side with evidence over conventional wisdom.
Well, the suits, we don't have data on that, because you guys all know this, that the suits come from anger and challenges in the doctor-patient relationship, probably 90% of lawsuits. So, to make you all feel good, because I know you're all, you're UW residents, you're amazing people, patients love you. You're very unlikely to get sued in that, because just for that reason. But at the end of the day, it's going to come down to evidence. And when you are doing the right thing, you're generally going to do right. Does that mean that there couldn't be a lawsuit that's solved, that they don't get an expert, they get an expert witness who's a total idiot, and they don't find, the expert witness who's following the evidence, the jury doesn't understand it. But again, that's a minority. But we don't have studies that really, that's a great, wonderful question. And I would love it if any of you have an interest in that type of thing. That would be a great study to look through legal cases that have been awarded to juries and see if that is an issue, but I haven't seen that. Other questions?
Other question was regarding B12 replacement.
Yeah.
Wondering if any of those patients in the studies that you mentioned had coexisting neurologic manifestations of B12 deficiency.
So those studies, they were all anemia studies. They were individuals who had pernicious anemia with, I think all of them had anemia, and some of them did have neuro findings with that, but that was not their endpoint. Everything was pretty much anemia cases. Now, what they did do was follow those people prospectively in that 1968 study and found no neurologic problems. And the blood study also found those patients were fine, and they felt because their B12 levels were so good, they didn't worry about a neurologic problem developing on oral therapy.
All righty, thanks so much. Any other questions, folks?
So the question on expiration date for condiments, I'm kind of lazy, so I look for how much mold is growing. If it's enough I can scoop off, I'll still use stuff. I don't recommend that approach, but okay, well, it's been really fun to talk to you folks again. Would love to speak to you guys again if it's ever helpful. I got a whole bunch of other sort of bizarre talks.
Cool. Thank you, Dr. Paauw.
Okay.
Interns, if you're still here, feel free to go over to ICC. Otherwise, the rest of you have the morning off. So have a good one.